Hello, my name is Srđan Verstovšek. I'm a professor of medicine in the leukemia department at MD Anderson Cancer Center in Houston, and here I'm reviewing the most important findings at American Society of Hematology meeting 2016. We'll start with a poster on a pooled overall survival analysis of a 5-year data from a COMFORT-1 and COMFORT-2 trials of Ruxolitinib in myelofibrosis. And here, after 5 years, a combination of the two studies was analyzed in terms of overall survival. And it's quite clear that earlier institution of Ruxolitinib prolongs the life of the patients, and it is about 3 years of a survival advantage of the patients that were exposed to Ruxolitinib comparing to those that were never ever exposed to Ruxolitinib, or if they were exposed to Ruxolitinib at a later time point during their life, the extension life is about a year and a half. And that was independent of any characteristic of the patients at the time of enrollment. Follow-up to this study is another important presentation on what we call a landmark survey, which was a quality of life and productivity survey of the patients living with the disease, myeloproliferative neoplasms, which went beyond just looking at the symptoms that they suffer from, which are very well known by this time and age. Here we were looking at the disease impact on daily activities, impact on patients' work, and overall activity impairment, which is significant. And this applies to patients with ET, essential thrombocythemia, polycythemia vera, as well as myelofibrosis, where one would think that patients with more benign conditions, ET and PV, have relatively less impact of the disease on their daily activities, work, and overall impairment. And this is not so based on this report. There is also a report of a JUMP study, which is an open-label, multi-center, single-arm expanded access study of Ruxolitinib myelofibrosis in more than 2,200 patients around the globe, which just confirm in a community setting that indeed Ruxolitinib is very active for spleen and symptoms, with a notable myelosuppression that is not usually a reason to stop the therapy. Manageable myelosuppression in community setting does not lead to early stopping of the therapy, and as shown in a JUMP study, over time, in fact, the results get better and better in terms at least on the spleen response. The long-term aspects of Ruxolitinib on patients that are taking it that have myelofibrosis were highlighted by looking at patients' bone marrow over time. Dr. Kwasnicka presented a bone marrow morphology in patients with myelofibrosis enrolled in COMFORT-1 study, and it showed that after years of therapy, after 4 years of therapy, a good proportion of the patients, in fact, have improvement in bone marrow fibrosis grade, one of the aspects of the benefits of the therapy in patients that are sustained on a good effective dose of Ruxolitinib over time. Moving on to studies with Interferon, we would like to highlight the final results of a PROUD-PV study, a randomized controlled phase 3 study comparing Ropeginterferon, a new long-term version of Interferon, which is given under skin every 2 weeks, to Hydroxyurea in patients with PV, so a relatively more prevalent disease, but less aggressive than myelofibrosis, where we worry about blood cell count in particular, to some degree also about the symptoms and the spleen, but the goal of therapy is to decrease the thrombotic risk. And in this randomized study, patients that were naive to cytoreductive therapy or previously exposed to Hydroxyurea, which about a third were, but less than 3 years in duration, were randomized to receive Ropeginterferon or Hydroxyurea, and after 12 months of randomization, the efficacy was analyzed, and the responses between two arms were about the same. This was indeed a non-inferiority study, where complete hematological response was about 45% on both arms. Continuation of that study beyond the 1 year was highlighted by information that, in fact, as I would say, expected after a longer period of time, after 3 to 5 years of therapy, there should be perhaps even a superiority of interferon to Hydroxyurea, but this is something that we will follow up in the next year presentations. In terms of the tolerance, Hydroxyurea indeed was causing more of a side effects in this particular study than Ropeginterferon, perhaps identifying a quality of interferon here which is much better tolerated because it's given so infrequently. On the other hand, another phase 3 study, which is a global phase 3 study comparing hydroxyurea and a different form of Pegylated. This is Pegylated interferon alpha-2A, or also known as Pegasus. And after 12 months of a follow-up in this ongoing study, so these are in preliminary findings, again, we did see non-inferiority, the same result between the arms treated with hydroxyurea or Pegasus, as noted, a different form of a long-acting interferon. That was shown at multiple levels, non-inferiority for control of the blood cell count, phlebotomy, and other aspects that we worry when we talk about polycythemia vera. Moving on to something more exciting, a new medication that in pilot study was tested in patients with myelofibrosis and significant anemia, a very small ongoing study, only 19 patients presented so far. This is an antibody that is injectable under the skin every 3 weeks. 2 doses were tested, and about 40% response rate in the lower dose, actually 0.75 milligrams per kilogram, with activity even in the higher dose. But the unmet need that this drug potentially can cover, which is anemia and myelofibrosis, for which there is absolutely no therapy, is in fact on its own a highlight of these preliminary findings, and hopefully we'll have this drug further developed in many more patients. So combination studies hopefully will also happen in a very near future. And finally, to conclude with a late-breaking abstract that was presented in an oral session at the end of ASH, these are results of the PERSIST-2 study, which is a phase 3 study comparing pacritinib, another JAK2 inhibitor, comparing it to best available therapy in patients that had platelets below 100,000. Best available therapy arm allowed patients to be prescribed Ruxolitinib if judged reasonable by the treating doctor. In this particular study, patients were required to have a low platelets because this is an area of unmet need. Ruxolitinib can be used, but very low dose can be used only in patients that have a platelets between 50 and 100, and not in patients that have platelets below 100. And low platelets can develop on therapy with Ruxolitinib, precluding proper efficacy of this agent. So certainly an area of unmet need. And here in this randomized study, pacritinib was better than best available therapy arm for control of the spleen. However, it was not better for the control of the symptoms. In subgroup analysis, one of the arms, and there were 2 arms of pacritinib, one of the arms, the pacritinib given twice a day, was better than a best available therapy arm. And that gives us a signal that perhaps further work needs to be done to define proper dose schedule and the area of proper use of pacritinib in patients with myelofibrosis. With that, I would conclude the summary of most important findings reported at this year's annual American Society of Hematology meeting. Thank you.